Good evening,
Hi, good
everyone.
evening.
I'll just introduce you first. Just a second, please.
Please. Sure.
Good evening, everyone. Thank you for joining for head and neck cancer, highlighting recent updates. Without wasting much time, I'd like to introduce the moderator for the session, Dr. Abhishek Kumar, MBBS MD Pathology, Head Anatomic Pathology on Quest Laboratories Limited, Gurugram. Sir, over to you, sir, for the welcome address and overview.
Yeah. Hi, good evening. This is Dr. Abhishek Kumar, Head Department of Anatomic Pathology, Onquist Reference Lab. It is with great pleasure that I welcome you to the latest edition of Updates in Pathology hosted by Onquist Labs. Today's topic is head and neck cancer, highlighting recent updates. Today, we are delighted to welcome Dr. Nirmalaya Banerjee, an alumnus of PGI Chandigarh, from where he did his MD and DM histopathology and is currently serving as lab in charge, Netaji Subhash Chandra Bose Cancer Hospital, Kolkata. Dr. Banerjee will be discussing today changes in the latest AJCC guidelines related to the reporting of head and neck cancer specimens. We will, however, start the session with Dr. Ramneet Kaur, with whom I have the privilege to be working with currently. Dr. Ramneet has been associated with Onquist Labs since 2019. Today, she will speak on the newer entities in the head and neck pathology arena. Please type in your queries, which I will direct to the panelists for the Q&A session at the end of the webinar. So without further ado, I hand over the screen to Dr. Ramneet.
Thank you, Dr. Abhishek. Now, I'll start sharing my screen. Good evening, everyone. I'll be speaking about the update and newer entities in the head and neck pathology, starting with the tumors of the oral cavity and mobile tongue. So major changes which have been done in this latest classification of WHO classification of the tumors, that oropharyngeal tumors have been excluded. This has been put as a separate group because of the association with the HPV virus causing squamous cell carcinomas in the oropharynx. So, and other changes are addition of the soft tissue tumors, neural tumors like rhabdomyomas, hemangiomas, they have been added. And also lymphoepithelial carcinoma is included in the orosquamous cell carcinoma instead of a separate section which was previously in the previous edition of the WHO. Now starting with the another new entity, Myofibroplastic Sarcoma. It is a new entity. It's a low-grade malignant tumor seen in the oral cavity and mobile tongue. And it is a tumor which is composed of spindle-shaped cells and arranged in a herringbone type of pattern, and it is infiltrating, it is diffusely infiltrating into the surrounding soft tissue, surrounding adipose tissue, and the cells are slender with small nucleoli and mitotic figures can be seen. It is a low-grade tumor, and it has on IHC it has myofibroblastic immunophenotype, and we can highlight these by SMA, desmin, calponin, and other markers for the myofibroblastic differentiation. This tumor is a low-grade tumor, so it rarely metastasizes to lung, soft tissue, and bone, but recurrences in the local areas are common. Speaking about the hematolymphoid tumors, we have a common tumor in the this category, CD30 positive T-cell lymphoproliferative tumor disorder. It is most commonly seen in the oral cavity, and it affects the males in the males to female ratio 2:1, and it occurs mostly in the elderly age group. It presents with the mass with overlying surface ulceration, and on histopathology in the microscopic sections we see CD30 positive atypical cells present as sheets in the underlying subepithelial tissue. Another category is the traumatic ulceration with stromal eosinophilia. It is a reactive condition which is similar to the T lymphocyte proliferative disorder, but it is not related to the CD30 positive proliferation of the lymphocytes. Both the lesions are rapidly self-limiting lesions with rapid healing after the excision. But importance here is to say that it can be misdiagnosed, and it can be confused with the anaplastic large cell lymphoma. So we have to see whether it is benign condition like traumatic ulceration, stromal eosinophilia, or it is anaplastic large cell lymphoma. So basically, it is to distinguish, to prevent a misdiagnosis of anaplastic large cell lymphoma. Now moving on to the other lymphoma, which is plasmablastic lymphoma, which is seen in the oral cavity, and it is a highly aggressive B cell neoplasm and strongly associated with HIV, and it is a AIDS defining neoplasm. And if it is super infected with the EBV, then there is a surge in plasmablasts, and MYC gene deregulation is there, and which will enhance the further proliferation of this lymphoma. On IHC, these tumors are positive for the CD19, CD79A, MUM1, CD38, CD138, and they lack B cell markers. And it's a very mitotically active tumor. It is Ki67 is more or less very high, and it is related to the EBV virus. So EBER is there, and we can detect it by EBER-ish, which is positive. This microscopy, this slide shows sheets of lymphoid cells with large lymphoma cells and having a prominent nucleoli. Now coming to the nasal cavity and paranasal sinuses and skull base tumors, 3 new entities have been included in the WHO. They are nut carcinoma, seromucinous hematoma. It's a benign condition, and another tumor biophenotypic cyanonasal sarcoma. Emerging entities have also been enlisted, like SMART-B1 deficient carcinoma and Hpv related carcinoma with adenoid cystic features. Now, first speaking about carcinoma, nut carcinoma, it is defined by the rearrangements of the nut M1 gene on chromosome number 15. So, and the most common fusion partner is BRD4. It is mostly seen in the younger age group. Females are affected more than males, and signs most commonly are the cyanonasal tract, and mediastinum can also be involved. It is an infiltrative tumor with frequent involvement of the orbit and cranial cavity, and it has a very poor prognosis because it is rapidly metastasizing to the other regional and the distant sites. Speaking about this morphology, it is a tumor which can be confused with many other tumors of this site because it has undifferentiated morphology. There are sheets of tumor cells, and which can appear basophilic, which can appear undifferentiated, medium to large size cells with moderate to large amount of cytoplasm with prominent nucleoli. So, but one thing we should look for is the abrupt keratinization, which is frequently seen. So in small biopsies, we can miss this abrupt keratinization, and we can just label it as undifferentiated carcinoma. But now it is known that this entity exists. So we have to look for this areas showing abrupt keratinization. And now we have antibody IHC for this tumor, which comes positive if it is the nut carcinoma. And moreover, they are cytokeratin positive, P40 positive, and other neuroendocrine markers can also come positive, and TGF1. So it has it can be confused in many other tumors. So in this case, nut IHC comes into play. It has an important role for the diagnosis. So it can also be demonstrated by this is the IHC, which is showing diffuse nuclear staining with the nut antibody, and this is the fish, which is showing split apart signals, and which is a characteristic of this nut carcinoma. This carcinoma is not associated with HPV and EBV, and it is important to diagnose this because clinical response to some targeted therapy has been shown, and they are bromodomain inhibitors, which are now used for the treatment. So diagnosing this entity is important. Other category is the other new entity is the biophenotypic cyanonasal sarcoma. It's a low-grade cyanonasal sarcoma, and it is showing a biophenotypic differentiation, like it is showing both neural and myogenic differentiation. A rearrangement has been seen with the PAX3 and the partner being the mammal3 gene. It occurs in the middle-aged patients, especially females. 2:1 ratio is seen, and is seen mostly in the nasal cavity ethmoid sinuses, presenting with obstruction of the nasal cavity and facial symptoms. Now, this figure shows the histology of the biophenotypic cyanonasal sarcoma. It is seen as a subepithelial mass. It is a proliferation of the spindle cells, which are seen as a herringbone in a pattern, and some staghorn type vessels are also seen, which can be confused in by other tumors like SFTs and hemangioparasitomas. They are also one of the DDs of this tumor. Nuclei are pale, slender, and uniform. Not much atypia is seen. Mitotic figures are also very less, and no necrosis is seen. It's a low-grade tumor, and we can take the help of IHC, in which S100 for the neural marker and the actin for the myogenic marker is helpful to diagnose this biophenotypic cyanonasal sarcoma. So we have very many DDs like schwannomas, MPNST, hemangioparasitoma, SFT, synovial sarcoma. So we have to distinguish with these by applying the PAX3 antibodies available, and PAX3, by using this, it is positive in only this tumor and negative in all the other tumors. Also, we have this rearrangement, which can be detected by cytogenetic studies. Behavior-wise, this is a very slowly progressing tumor, and local invasion into the bone is seen. But yet now, no metastasis have been seen in this tumor. Now, coming on to the next entity is the SMARCB1 tumor, cyanonasal carcinoma. It is a tumor which shows lack of INI1 or the SMARCB1 gene, which is located on the chromosome number 22. The features which are peculiar are rhabdoid features, which can be seen in many other tumors like pediatric atypical rhabdoid, teratoid rhabdoid tumor, rhabdoid tumors of the kidney and soft tissue, and epithelioid sarcoma, and many others. Behavior-wise, it is it shows a very grim prognosis. Regarding the histology, it is a very highly infiltrative tumor seen as a epithelioid nests and trabeculae of the tumor cells, which are showing a lot of tumor necrosis, high mitotic rate, and these cells may itself appear basaloid, resembling the undifferentiated carcinoma or non-keratinizing squamous cell carcinomas. Sometimes they may have myoepithelial or oncocytic appearance. So if we know this tumor occurs in this area, particularly the nasal cavity, we have to keep in mind. So by doing the SMARCB1 immunohistochemistry, we can diagnose this tumor, because there is a loss of this expression in the tumor cells, and the stained cells are the internal control or the blood vessels or inflammatory cells which are positive, and the tumor is negative for this IHC, INI1. So it also shows, it is a carcinoma, it shows CK positivity, and it can be also positive for various squamous markers, neuroendocrine markers. But the only thing is, it is showing loss of INI1, so this should be applied for the time. These cases are not associated with HPV or NUT gene the mutation, and so PISH also can be used for the detection of this loss of gene. Behavior-wise, this is very aggressive tumor, and local invasion and metastasis are common. Moving on to the other category, entity is the HPV related carcinoma with the adenoid cystic features, and this is described only in the cyanonasal tract. It is a cyanonasal tract is the second hotspot for the HPV related carcinomas, second only to the oropharyngeal areas. Regarding this name itself says that it is related with the HPV, and so the HPV type is related is the high risk type HPV, and females are affected more commonly than the males. This is the histology showing the solid nests and tumors. This is just like adenoid cystic carcinoma morphology, but it shows the squamous, the surface epithelium shows dysplasia, and these nests and trabeculae are formed of basaloid cells showing cribriform structures and microcystic pseudoductal spaces. And in addition, we have some eosinophilic cuboidal cells. These duct-like structures are positive for CK7, and these smaller myoepithelial cells are positive for myoepithelial markers like S100, calpain, P40, and actin. But it is associated with HPV, so high-risk HPV is detected by RNA in situ hybridization, and diagnosis can be made. So one thing is important, that squamous dysplasia of the surface epithelium is seen in many cases, and it is an important feature. And P16 highlights these dysplastic cells. Mitosis is very high, necrosis is present. It's a very aggressive tumor, and positive high risk HPV type 3 is detected most often. But unlike adenoid cystic tumor, adenoid cystic carcinoma, this tumor does not show perineural invasion so commonly, and it also does not show MIB gene fusion as seen in the adenoid cystic carcinoma. But later on, this tumor has been renamed, this entity has been renamed as human papillomavirus related multiphenotypic cyanonasal carcinoma, as it shows, apart from the adenoid cystic carcinoma, many other phenotypic features. Like, and also IHC is positive for many other differentiation, like myoepithelial markers are positive, squamous markers are positive, and P16 is consistently positive because it is related to the papillomavirus, so it shows diffuse and strong nuclear cytoplasmic staining. INI1 is retained. So now I'll move to tumors of the salivary gland. First of all, it's the secretory carcinoma, which has been added as a new category. Secretory carcinoma is the recapitulation of the secretory carcinoma of the breast, and it shares the ETV6 NTR K3 gene fusion. It is histologically resembles actinic cell carcinoma, but differs in some features. Like histologically, features, the growth patterns are similar, but these tumors, they show multivacuolated eosinophilic cytoplasm and intracytoplasmic mucin, but there are no true zymogen granules which are seen in actinic cell carcinoma. Also, on past staining with diastase, the pattern of the staining is globular, which is indicative of mucin, whether while in actinic cell carcinoma, it is granular. And by immunohistochemistry also, we can distinguish this tumor with the actinic cell carcinoma, like S100 and mama globin are positive in secretory carcinoma, and it is negative in the actinic cell carcinoma. And DOG1 is used for diagnosis of actinic cell carcinoma, and it is negative in the secretory carcinoma. So this is the picture showing the histology of these tumors. First, A is showing the actinic cell carcinoma, which is showing the follicular pattern lined by the basophilic acinar cells. And on past staining, instead shows the past staining with the zymogal granular staining. But in contrast, the secretory carcinoma shows follicular pattern with vacuolated cells and mucinous luminal secretion. On past staining with diastase, the globular staining of the cells are seen along with the luminal staining. In by IHC, S100 is negative in the acinar cell carcinoma, and it is strongly positive in secretory carcinoma. This is showing DOG1 positivity in the acinar cell carcinoma, and the next figure is showing the mama globin positivity in the secretory carcinoma. So secretory carcinoma, behavior-wise, it is as same as actinic cell carcinoma, but it shows higher lymph node metastasis than the acinar cell carcinoma. But this is important to diagnose because we have now drugs against this carcinoma. So therapy which is available. This is larotrectinib and ectrenib. These are the drugs which are available for this tumor. So this needs to be differentiated from the other tumors. The other entity is a benign entity known as sclerosing polycystic adenosis. It is a new entity considered neoplastic. It has shown resemblance to fibrocystic disease and sclerosing adenosis of the breast, and most commonly seen in the parotid gland. And it is composed of well circumscribed tubulocystic proliferation of glands within a sclerotic stroma. Duct morphology ranges from intercalated duct to apocrine. So, but the characteristic feature of this is presence of acini with aberrant coarse red zymogen granules. This is the morphology microphotograph showing cystic proliferation of glands in the sclerotic stroma, and many times we see apocrine and secretory areas with histiocytes, and the acinar cells show typical coarse zymogen granules. This is a characteristic feature of this entity. This entity is now considered neoplastic because chromosomal changes has been studied in the X chromosome, and inactivation has been proven by the studies, chromosomal studies. And this entity, when this excised, it is recurrence rate is high because it is mostly incompletely excised, and because it is multifocal, so recurrences are very common. So also this has become important because this lesion can become proliferative with appearance similar to intraductal carcinoma. Coming to the hematolymphoid tumors, these tumors have been enlisted in the 2017 classification of the head and neck tumors. I'll be talking about these three tumors. First of all, CD30 positive T-cell lymphoproliferative disorder, as explained in the oral cavity. It occurs in the older adults, and it is a mass presented with a mass with ulceration of the surface epithelium and showing proliferation of the CD30 positive atypical lymphoid cells. And rearrangements have been seen involving the DUSP22 on the chromosome number 6. It has shown complete resolution with local therapy. Moving on to the next entity, this is extranodal NK cell lymphoma. This lymphoma has a cytotoxic phenotype, and it is associated with Epstein-Barr virus, and this is mostly found in the upper aerodigestive tract. The characteristic, and it is mainly derived from the NK cells, and minority arises from the T cells. The characteristic feature of this lymphoma is it has an angiocentric growth surrounding necrosis. So this is the vessel, and the angiocentric growth is seen with the surrounding necrosis. And the tumor cells are monotonous, intermediate-sized atypical lymphocytes showing CD56 positivity, and also EBV positivity by the in situ hybridization. So many tumor genes have been studied to be mutated, like on the chromosome number 6. And in addition to TP53, DDX36, another commonly mutated tumor suppressor gene has been noted. JAK-STAT pathway is activated, which leads to frequent genetic alterations, and EBV is associated with the pathogenesis of this lymphoma. Now moving to extraosseous plasmacytoma, it's a tumor formed by the clonal expansion of the clonal proliferation of the plasma cells in the absence of underlying plasma cell myeloma. It is mostly seen in the upper respiratory tract, and morphologically it is composed of sheets of plasma cells with clumped chromatin and abundant eosinophilic cytoplasm. So these plasma cell markers are positive, and CD20 PAX5 is negative. Now coming to the paraganglion tumors. So these tumors, they in the head and neck, they are seen in the 4 areas: carotid body, middle ear, vagus nerve, and the larynx. So what is important in this, that 30 to 40% of these head and neck paragangliomas are familial. And we have to see, because if paragangliomas are seen in these areas, we must do this gene mutations studies involving the succinate dehydrogenase pathway. So because they are mostly involved in the other syndromic tumors, many other tumors are also involved because these are genetically inherited tumors. So and these tumors are not benign, just misnomer, just they behave as a malignant tumor. They invade the vessels, they show mitosis, necrosis, and they are known to metastasize. So they behave like a malignant tumor, and loss of this expression, SDHP expression, by immunohistochemistry is a valuable screening tool to identify any succinate dehydrogenase gene mutation, any of the genes in the tumors. So morphologically, it shows a typical morphology of the paraganglioma, like Zell-Berlin pattern is seen, showing the clusters and nests of tumor cells, which are separated by the fibrovascular septa. And normally the SDHP expression is seen in the cytoplasm. It has a granular positivity. But if there is loss of this gene, then these cells show no staining by this IHC, and the internal control, inflammatory cells and the endothelial cells are positive. So we have to make sure if that this is deficient, and in cases of heavily infiltrative, in the cases where there is heavy infiltrate of inflammatory cells, these tumor cells might be we can miss these cells, because they are if they are deficient, we may miss, because In these, particularly in these type of cases in which there's a high inflammatory component, we have to be very careful to find this loss of SDHP expression. So I've already mentioned that paragangliomas are associated with many tumors, like they are associated with renal tumors, GIST, and pituitary tumors. And the most common SDHP gene is the most common paraganglioma syndrome is associated with the loss of SDHD type of the gene. And SDHB gene is mostly involved in metastasis. And we see metastasis in intra-abdominal, and other associated tumors are intra-abdominal, the pelvic paragangliomas. Now, something about metastatic squamous cell carcinoma of the unknown primary. And if the primary is not known, and metastasis is seen in the lymph nodes, and if they are positive for high risk HPV, then mostly the primary must be in the oropharyngeal region. And also, if the lymph node metastasis have pushing borders and expansion of the lymph nodes rather than infiltrative morphology, extensive infiltration of the surrounding tissue, then also we should think out about the primary in the oropharyngeal region. Other thing is when the cystic, when the lymph node metastasis shows cystic degeneration, when they are cystic in nature, also we should think about primary in the oropharyngeal region. But if there is EBV positivity, then the primary must be in the nasopharyngeal region. So this is all about the new entities. Thank you.
Thank you, ma'am. Very enlightening session. I hope if there are any questions, you can put it on the chat box. I'll now invite Dr. Nirmalaya to continue with his presentation.
So am I audible?
Yes, sir, you're audible.
Okay. So my screen is visible?
Not yet, sir.
Now?
It's showing, yes, sir, it's visible now. Request you to make it full screen.
Okay. So it's visible now. So
yes,
shall
sir.
I start?
Yes, sir, please go ahead.
Okay. So good evening, everyone. Myself, Dr. Nirmalaya Banerjee. I will be discussing mostly about the pathological aspect of the assessment of the head and neck cancers, basically. And I will emphasize on those areas where a pathologist, a histopathologist or an oncopathologist should give stress so that maximum amount of information is passed through the surgeon. So the purpose of today's discussion is what are the things which AJCC endorsed in 8th edition regarding the head and neck cancer, and what are the things which must be there in a comprehensive report of a head and neck tumors, precisely cancers. So I will start with the introduction. So most of the head and neck cancer, and I will request to the host that if anything interrupting, please let me know. Okay.
No, sir.
Okay. So if you see, most of the head and neck cancers are derived from the mucosal epithelium of the upper aerodigestive tract. Mostly in day-to-day practice, most of the tumors which we see are deriving from the mucosa of the upper aerodigestive tract. And there are so much of newer entities, subclassifications, provisional entities are being emerged in the current years. This is because of the ongoing and intense research basically related to the tumor biology and site-specific etiology. And the 8th editions, they characteristically incorporated few entities, especially the HPV related disorders, like you have seen in the previous speaker have said, HPV related adenoid cystic carcinoma. And there are so many changes related to the usual entities. So all of this I will be discussing, and I'll emphasize on the reporting part also. So let's have a look, an overview. What are the changes have AJCC has recommended in the last edition, and what are the changes which is more obvious in the 8th edition from the 7th edition? So first is the separate staging algorithm. This is very important. Separate staging algorithm with the HPV related cancer. Secondly, AJCC has dedicated one chapter of head neck specific cutaneous malignancy. This is very important. See, if you see the classification AJCC has written on the review article which he has published, they have that oral cavity, oropharynx are the separate chapter. Cutaneous malignancy of the head neck region, the separate chapter. Why? I will discuss on the next few slides. Thirdly, they have divided pharynx into three components: nasopharynx, oropharynx, hypopharynx. Why so? Because the tumor which occur in the nasopharynx, which is the potential space bounded by the choana, they have a typical tumor biology, very specific metastatic potential, and they have a different kind of a therapy. Whereas the tumor which are related to oropharynx and hypopharynx, they are completely 180-degree different from the nasopharynx. So this is the rationale of the division of the pharyngeal tumors into three components. Next is the change of the tumor T categories. See, this is extremely important, and this is the most vast topic. Every site you will find another T classification. So whenever you are reporting a tumor, you have to know and you have to ask your radiology counterpart, where is the epicenter? If you are dealing with an oral cavity cancer, that your T, and you are dealing with a tumor which is related to the larynx or the hypopharynx, your T will be different. So this is number 4 change. Number 5, addition of DOI. DOI means the depth of invasion, which actually determines the T characteristics in the oral cavities cancer. Let me tell you, in day-to-day practice, which I usually get most of the cancers in the oral cavity, most of the cancers. So DOI, you have to understand what is the DOI, what is the depth of invasion, which actually determines the aggressiveness. And the last but not the least, the nodal metastasis. And in the nodal metastasis, ENE has been described vividly in the AJCC 8th edition. So I'll be discussing one after one in the next few slides. So first start with the T changes, right? So what are the T changes? See, AJCC has eliminated the T0 category from all the slides except the nasopharynx and oropharynx. I will tell in the next slide what is the rationale behind this change. In the nasopharynx, the previous T4 criteria of the masticator space and infratemporal fossa has been replaced, and now they say that it is the soft tissue involvement which regulates the T4. Now, masticator space and the infratemporal fossa are not the only two spaces. There are other spaces also which determines the T4 nature. Same time, I want to say that exclusion of medial and lateral pterygoid and prevertebral muscle, which was previously designated as T4, now called T2. This is extremely important. Medial lateral pterygoid and prevertebral muscle involvement is T2. And at the same time, depth of invasion has been added as a modification of the T to the oral cavity cancer, which actually determines the aggressivity. Now, what is the rationale of elimination of T0? See, what is the T0? First, you have to understand this. T0 is basically described by the previous AJCC, where patient present with the nodal mets, but you can't find the tumor. That means the occult primary, and you have a lymph node positive. Now, what will you do? You will take help of the either to the histopathologist, you will do a biopsy, or you go to the radiology, or do both. So this concept has been largely challenged in the latest edition because they say this concept is not at all consistent with the anatomical site staging. Why? Because if you get a biopsy from a lymph node positive and you get a Hpv positive or P16 positive, which is a marker of HPV, most of the cases Hpv positive tumors are related to the nasopharynx, and P16 positive, which is a proxy marker of HPV, it will be related to the oropharynx. So only in those two cases or those two sites, to be precisely, you can use the term T0, except you are not allowed. For other sites, the specific grading system has been designated in the chapter carcinoma with unknown primary or CUP, where you will get the nodal mets, ENE, and the clinical parameters to judge the gradation of the tumor. But in those two sites, you will use the T0. In rest of the cases, you will not go by the conventional classification system. You have a separate classification system known as the carcinoma with unknown primary. Hence, it has been eliminated. So here comes the depth of invasion. Now you see, depth of invasion actually determines the T nature of the tumor. If it is less than 2, it's T1. 2 to 5, it's T2. And if it is more than 10, it's mostly T3. So what is depth of invasion? How we measure that? And what is exactly the depth of invasion is related to? See, this is the graphical diagram to understand. See, if this is an exophytic tumor, you see, and this is a normal adjacent epithelium, and this is the basement membrane. So even if an exophytic tumor or an ulcerated tumor, you have to just draw an imaginary line connecting to the basement membrane of the adjacent epithelium. You just have to draw, and then you draw a plumb line connecting to this horizontal line and the maximum tumor depth to this vertical line will actually determine the DOI. So sometimes in the DOI will be much lower than the tumor thickness. Sometimes it can be higher, but whatever the DOI is should be represented in the report. Because if you see, this is a plumb line, this is a microphotograph of an oral cavity tumor. This is the normal adjacent epithelium. We are drawing a line this, and there we are joining this. This is the maximum extent of the tumor. This is 9 mm. So you should write the DOI is 9 mm because it determines the T nature. This is the ulcerated tumor where the same principle has been. And you see in this case, the DOI is actually higher than the tumor thickness, but it doesn't matter. The DOI actually determines the T natures of the tumor. The same thing which I have said previous, the T1, T2, T3, and T4. So if it is a DOI more than 10 and tumor size more than 4, you are dealing with a possibly moderately advanced local disease. So that is the importance of the DOI. In addition to DOI, most important thing which I want to emphasize in this seminar, what is host pattern of invasion? This has been also vividly described in the AJCC 8th edition. Now you see, the concept of WPOI comes from the maximum dissemination of the tumor from the tumor perimetry. So type 1 to type 5 has been classified by the AJCC, whereas 1 to 3 is called as the non-aggressive form, and 4 and 5 known as the aggressive form, right? So am I audible?
Yes, sir, you are audible.
Okay. So type 4, if you see if you look carefully, type 4, you see there are small tumor island of 15 cells or fewer than cells per island. And in type 5, you see the tumor satellites, which could be more than 15 cells with more than 1 millimeter or at least 1 millimeter dimensions. I mean, the distance. So in your report, I mean, it is not possible every time to report type 1 or type 4 or type 3. You just have to mention in your report whether type 5 is present or not. Because if it is type 5, you are dealing with a tumor with a poor prognosis. So this is the important of now how it looks. See, this is photo micrograph. This is the tumor perimetry maximum. And these tumor satellites are far away from the main tumor perimeter. And if you look at this is more than 1 millimeter. This is also more than 1 millimeter. So the tumor cells are more dispersed and far away from the main tumor perimeter. That is the concept of WPOI. So even if you can see 2 lymphatic emboli are 1 millimeter away and it is away from the main tumor perimeter, call it WPOI 5. Similarly, if you see tumor with perineural invasion and it is far away from the main tumor, then also you call it as WPOI 5. And regarding PNI, which one must remember that PNI is, when PNI is there, you are dealing with possibly a case with WPOI 5. Because if you read carefully AJCC endorses PNI as a very poor prognostic marker. So therefore, you have to understand what is the definition of PNI. You can't call PNI like just, you have seen few cluster of tumor cells in the nerve bundles. You can't call it as PNI. If PNI is there, you have to mention whether it is focal or multifocal. If it is multifocal, then you are possibly dealing with a tumor with poor prognosis, and it is whether it is intratumoral or it is outside the tumor. That is also you have to need to mention. So what is the definition of PNI according to AJCC? Wrapping around the nerve must be there to call it as a PNI. Merely bumping into a nerve does not constitute a PNI. So you have to be very careful while reporting that whether you are dealing with a multifocal PNI, whether you are dealing with an intratumoral PNI or extratumoral PNI, how frequently you are getting your PNI, and if possible, you have to mention the nature of the PNI. You know, some review article you see, I mean, there are a lot of review articles are coming. They say that PNI means vascular invasion and perennial lymphatic invasion. But although there is a lot of doubt regarding this, but whatever be the reason, PNI should be taken very seriously in case of head neck cancer reporting. Fine. So this is one of our case. In fact, today's case, right? This is a tumor which I have seen in the oral cavity, just awaiting the hard palate. You see this? This is the main tumor, right? And see the dispersed tumor islands far away from this. So this is WPY5. And in high power, if you see, you can see this type of typical strandy pattern of invasion. This is known as strandy. You see the tumor clusters in a desmoplastic bluish stroma, and the tumor satellites are separated more than 1 millimeter. And unfortunately, the patient is having bone invasion. You see, this is the tumor cells. They are decalcified sections. These are bluish. They are the bony trabecula, and tumor cells are largely infiltrated into the orbital floor. I mean, the floor of the maxilla. So this is a bone invasion. So if you are getting a WPY5, possibly you are dealing with a tumor with poor prognosis. This guy has a bad luck. He has a T4A. So possibly T4B. So this is how we discuss PNI, DOI, and WPOI. Now come to the nasopharynx. Why the nasopharynx has been given a special importance? Now it's a potential space. Nasopharynx is a potential space bounded by the anterior-posterior corner and extend along the plane of the airway to the level of the free border of the soft palate. Now in NPC, the histopathologist's role is very limited. Why? Because histopathologist will just say whether the tumor present or not. I'll come to detail. But one thing you must remember in case of nasopharyngeal cancer, whether the tumor has infiltrated the posterolateral directions. If it is posterolateral infiltration present, it's T1 to T2, it will upstage the tumor. And in addition to that, I want to mention isolated nasal cavity and oropharyngeal involvement is immaterial. You have to remember it carefully. Nasal cavity involvement of a nasopharyngeal cancer or oropharyngeal involvement is immaterial. It will not upstage the tumor until unless it's a posterolateral infiltration or retropharyngeal infiltration, right? So what are the unique features? Why so much of discrepancy regarding NPC tumors, and what are the exclusive features? Now, you see, NPC often present with an early lymphatic spread. It will give you a hint that yes, I am there, I am metastatized to the lymph node, and it has some specific nature of its lymph node mets. It's often involved bilateral lymph node chain, and it almost always follows an orderly fashion. It will start from up and then go below, and skip metastasis you won't see so frequently. And midline nodes, in case of NPC, you please consider it as an ipsilateral node. Don't make a mistake. Ipsilateral lymph node, midline node, you should not consider it as a contralateral node, and don't upstage it. It's an ipsilateral node if the midline nodes are involved. And if any nodal involvement, or if the radiologist says yes, the nodes are there below the caudal border of the cricoid cartilage, again, it's a poor prognostic parameter. And isolated involvement below the clavicle, considered as a distant metastasis. So you have to have the knowledge of why NPC has been given a separate entity or has been discussed separately. Last but not the least, I want to mention that please, in case of NPC carcinoma reporting, don't say well differentiated, moderately differentiated, poorly differentiated, because whatever you report, ultimate therapy is the radiotherapy. I will discuss it. You see, now this is the MRI of a base of the skull. This is the 7th edition classification. This is the proposed 8th edition. I mean, now the 8th edition is going. So you see carefully, this masseter and temporalis, including parotid gland and adjacent soft tissue, has been classified as T4. They have excluded lateral medial pterygoid, prevertebral and carotid space and left it for T2, which was previously included in the 7th edition as T4. So we have now the better understanding regarding the NPC biology. We have categorized it. What is T4? We know the prognosis. We know if the lateral medial pterygoid involvement is there, it must not upstage the tumor, and we will label it as T2. On the same time, lymph node involvement below this line, I mean the caudal border of the cricoid cartilage, you must mention that this is a poor prognostic parameter. So what I was saying, that please don't give well and moderate a differentiator, because it's hardly matters to the therapy, because ultimately it will go to the radiotherapist with or without chemo. So therefore, don't pathologically classification is irrelevant, and surgery to the primary node is used only. This is also very important for recurrent tumor, and chemotherapy is for advanced locoregional disease. Now, at the same time, nasal cavity and paranasal sinus also have been given equal importance by the AJCC. Why? Because bone involvement, which is conventionally T4 in case of oral cavity, whether it is in case of nasal and paranasal sinus, it is hardly T2 or T3. Now, how it is, we will see. See, this is a photo this is a coronal sections of a tumor located in the maxillary sinus, and it is T1, it is confined to the sinus. The moment it is involved posterolaterally, it upstages as T2. Whereas ethmoid sinus involvement anteriorly, or the involvement of the orbital floor, makes it as T3. And only orbital apex involvement or anterior orbital content involvement will make it as T4A. Orbital apex isolated will make it as T4B. So when you are dealing with a tumor confined or arising from the maxillary sinus, please remember that your T classifications will be entirely different. Bone involvement has a different classification, and you must ask your radiologist where the tumor is coming from and where it is going. According to that direction, you have to stage the tumor. So this finishes my T classification. Now I will concentrate on the extranodal extension. So what is extranodal extension and why it is important? Now see, ENE is an extension of a tumor, metastatic tumor within a lymph node, and it occurs through the capsule, transcapsular, and it deposits into the surrounding fat connective tissue, and it may or may not react with the stromal tissue. So ENE has been classified into two broad categories: ENE MI or microscopic, or ENE macroscopic. Less than 2 and more than 2 is the classification, is the cutoff point. So this is one of my case. You see, this is a lymph node with the Mets. This is a ENE. The tumor clearly permeates the lymph node capsule and present in the adjacent soft tissue. So this is ENE. This case was a gross ENE was there. Okay. So one of the largest study has been done by the TMH Mumbai under the leadership of Dr. Shubhada Kani. You know what she has done? She has classified ENE into 4 grades, and she correlated with the disease-free survival and overall survival, and possibly gives one of the best idea why we are dealing with, well, we are giving more importance or discussion regarding ENE. You see, they have classified into 4. Grade 1, with the tumor confined to the substance of the lymph node. 2, metastatic tumor extending to the perinatal tissue but less than 1. 3, metastatic tumor extending perinatal tissue more than 1 or completely replaced. Now we will see how this ENE actually correlates with the survival outcome. Lymph node density, of course, the number of positive lymph node is negatively correlated with the disease-free survival. Yes, of course, it is important because of lesser p-value we are seeing here. ENE of more than 2 or grade 2, of course, yes, it is related to the poor overall survival and disease-free survival. ENE grade 3 and 4 with 3-year overall survival is just 18%. So now you understand why the AJCC or UICC have given a lot of discussion regarding ENE and why it is necessary to mention in the report. And you must mention if you are getting a gross ENE, either in your gross, or you can just correlate with your macroscopic finding and change your gross. This is very, very important. Gross ENE you have to mention in your report. Now, coming to the cutaneous carcinoma, as I have said that they have separated a special chapter for this. The reason is basically this, T3. You see, they have clearly mentioned a tumor more than 4 centimeter of maximum dimension or minor bone erosion or perineural invasion or deep invasion is T3. Now, what is deep invasion? We will know now. Now, in case of cutaneous carcinoma, deep invasion is considered more than 6 millimeter. This is very important. This is the the cutoff point. And PNI is defined a tumor within the nerve sheath or nerve line deeper than the dermis or more than 1 millimeter or larger in caliber. The tumor dimension should be more than 1 millimeter. So if these are present, you call it a deep invasive tumor and it is related to the T3. Rest of the things are same. Now, last, I will discuss about the novel entity of HPV mediated oropharyngeal cancer. So although in India, the incidence is not much, but in Europe and in case of Middle East, the incidence are gradually rising. So it's important to understand the tumor biology of HPV related cancer. So it's mostly related to the oropharynx and it poses certain challenges to the pathologist and it has some unique clinical histomorphological features. What are those? Number one, it usually occurs in younger and healthier individual and usually not related to the smoking. This is very important. If a patient comes to you of 30 years, 25 years, healthier individual with no history of tobacco, possibly you are dealing with the oropharyngeal. If oropharyngeal mass is there, it should be HPV related and usually have a relatively better prognosis. And mostly 16 and 18 are the types which are detected transcriptionally in HR-HPV types. So you have to understand now why we do P16 IHC in HPV related tumors. Now, P16 is a surrogate marker, first of all, it's not a direct marker. P16 is usually upregulated when HPV16 oncoprotein degrades cellular P53 or nuclear P53 and RB. Now, once it is degrades, this oncoprotein gets degraded, P16 is upregulated. Naturally, P16 will be upregulated, so therefore we count it as a proxy of HPV related cancer. And it usually arises, listen very carefully, from the reticulated epithelium lining the crypts in the oropharynx, mostly in the tonsillar region, where in the reticulated epithelium, the basement membrane is incomplete. Therefore, in oropharyngeal carcinoma, please remember the in situ carcinoma concept does not apply. As HPV related malignancy arise from a reticulated epithelium where the basement membrane is incomplete, the concept of in situ carcinoma does not occur in oropharyngeal carcinoma. It represents a distinct form of head neck squamous cell carcinoma. I'm repeating again. So how you interpret the P16 IHC? This is again a most important and widely discussed topic. Now, P16 usually comes two types. Either you will get positive or you will get negative. Now, distinct positive again divided into two types. There is a specific cutoff point and criteria. Strong and diffuse positivity of 2 to 3 plus of more than 70% distribution considered as distinct positive, and weak to limited staining is considered as negative. Now, again, CAP has slightly modified this positivity. They said that 2 to 3 plus positivity of nuclear staining should be considered as positive. So this 70 to 70% is very arbitrary, right? So if you are dealing with the case of P16 positive HPV SCC, then possibly nuclear stain of more than 70% cell should be taken as positive. So patchy positivity or slight positivity, you have to discard it and you have to take it negatively. So out of these four, you will take this as positive. You will not take this as positive, and no question of taking of these two positive. So this is how you have to interpret P16. How it is different in morphologically, excellently described in AJCC. You see this basaloid morphology. You see it's high NC ratio, scanty cytoplasm. You see, this is a basaloid morphology. This tumor comes as a basaloid tumor. And no overt keratinization, no overt keratinization. Maybe in high power you can see some keratinization, but in every field you can't find keratinization. And inside out maturation. I mean, this periphery you can see some of mature cells with little squamous keratinization. At the central cells are totally immature basaloid. Sometimes this type of anaplastic cell you can get, and this is a poor prognostic marker in this particular scenario. So will you call it as a basaloid SCC just because basaloid morphology is there? No. AJCC does not endorse the term basaloid SCC for HPV related SCC. Do you use purely differentiated squamous cell carcinoma like any other tumor? You see basaloid, people are tempted to make a diagnosis. No, you will not pick. Why no? Because it will give a wrong notion to the clinician that possibly they are dealing with a poor tumor. No. Basically, they are dealing with a tumor with basaloid morphology, but with a good prognosis. Therefore, oropharyngeal tumor with non-keratinizing SCC is the proposed terminology, right? So you should not use the term basaloid or PTC SCC. Rather, you should just say non-keratinizing SCC. Advise P16 for correlation. Mets is also very unique in HPV. You see this kind of cystic Mets and absence of ENE. So therefore, P16, if you can get P16 positivity in the node, possibly you are dealing with a case of a oropharyngeal carcinoma with nodal Mets. So that is why the T0 is applied in this case. And another beautiful type, histological type has been, although rare, has been described. It's typical ribbon-like. You see this ribbon, thick trabecula, this jigsaw puzzle, and this sort of lymphoid stroma. So sometimes it is misdiagnosed as malignant transformation of the branchial clefts. Please don't make, before making these diagnoses, you have to be double sure, because often you are dealing with these sort of cases where you are dealing with a tumor sitting in the oropharynx, and this is just a lymph node mass. So we have to be very careful. So what are the characteristic features? P16 nodal status is unknown primary, is applied for T0 in HPV OPCC. No grading system. Again, no grading system. Just write non-keratinizing. You don't have to grade because it hardly matters. ISH can be done as an alternative, but it's costly, rarely available. So we use more often. In our lab also, I use P16. And if a tumor with OP cancer, if you are not getting P16 or IHH status, you simply say it is PSH negative, P16 negative. Because once P16 is done, then only your clinician will deal with as a HPV positive tumor. Otherwise, they won't, because therapy is widely different. The most common site of HPV related, neglected HPV, I will say, related tumor to the lung followed by bone. This is also a special feature. So what are the take-home message? I will finish now that before reporting, you have to be very sure where your epicenter of the tumor is. It's very important because your T stage and the biology of the tumor per se varies from site to site. Your friend of the radiology department will help you to determine the bone invasion, because sometimes it is difficult for us to determine the bone invasion. We sometimes confuse with the superficial erosion, but a good CT scan or MRI can tell you to the bone mets or to the bone invasion or to the soft tissue spread. Use judiciously the IHC and the molecular techniques, especially in case of OPC and nasopharyngeal carcinoma. So thank you very much. So I will finish with a great quote of Martin Luther, that we are all talking about the physical health of the cancer patients, but psychological or mental health is also given importance in AJCC. They say a depressed cancer patient has a poor survival. It negatively regulates his survival. So it's our moral responsibility to be with them, to boost them morally for a better life. Thank you. Thank you very much. Thank you, everyone.
Thank you so much, sir. Now I'll request Dr. Abhishek. Sir, we have some questions. I'll request you to please moderate the same. Dr. Abhishek.
Looking at the questions right now, there was
sir,
one that I have already answered.
Yes, sir, we have displayed on the screen.
There's another one that's for Dr. Nirmalaya.
Yeah.
It says, can you tell the criteria for bone invasion?
See, you see, there is no such defining criteria of bone invasion. You must understand, or you must have to differentiate between a superficial erosion and a cortical invasion. Now, I'll tell you a morphological. Let's go to the little bit morphology part. You see, a tumor which is on the GBS, on the gingival-buccal sulcus, it is moving towards the RMT or retromolar trigone, and it is just touching the alveolar ridge. Will you call it as a bone invasion? No, because your radiologist friend will say, see, I am getting a superficial bone erosion. So you must take a through and through section to the bone, must take a through and through section to the bone, and you must document that your tumor is permeating through the trabecula. Am I clear? Your tumor should permeate through the trabecula. Periosteal erosions or socket invasion, the tooth socket invasion is immaterial. If you are getting this, then yes, it is bone invasion, and you stage the tumor as T4B. Am I clear?
Dr. Vidya, I hope this has answered your question. So there's another question for EBV demonstration.
Yeah.
Will LMP1 help, or
Yeah.
is it always either-ish?
Okay, very good question. I mean, whosoever has asked. You see, LMP1 has a, it's a sensitive marker. I mean, I agree, LMP1, but let me tell you very seriously. Let's discuss about some other tumors related to EBV. See, in case of extranodal NK T cell lymphoma, which is also associated with EBV, will you use LMP to judge it as a EBV positive tumor? Will you? No. So you will do Iberish. So if you have an option of Iberish, always go for Iberish, because personally I have little dull experience with LMP1. I have done it LMP1. I reported is LMP1 positive. I'm speaking. Later on, it came Iberish negative. So LMP1, it's you have to take it very balanced way. Yes, LMP1 helps, but not always. So of course, Iberish is a gold standard. If you have, you can apply it. But the same system is not for P16. You can trust P16 if you have a good clone. You can have P16. You can trust HPV. Rather, you can avoid. Or if you have options, then you can go always. Of course, yes. I think I'm clear.
Dr. Suma, does that answer your query? Right, so there's another question from Dr. Suma. This is, does the size of nerve matter in PNI? Do you report that?
You see, yeah, AJCC, they say, see, there are two types of, as I have said, within the tumor or outside the tumor. But whatever be the diameter of the tumor, I mean, the nerve trunk, if you are transversely cut, it is vertically cut, whether it is covering at least 2/3 of the circumference. Remember, it is encircling the nerve caliber of the nerve. If it is yes, then you call it as a PNI positive. If it is no, then possibly you should not report it. You have to understand one fact, that when a tumor is within the nerve sheath, it will very soon engulf the subcapsular space. So most of the times we overrate it. I mean, majority of the cases I have seen, I mean, the outside report, they say PNI positive, PNI positive. But ultimately, if you take more sections of, if you do the block review here, I say there is no such PNI to confidently tell about. So if you see a wrapping of tumor cell around the nerve, you call it as PNI. Don't go for the diameter. Don't confuse it with the diameter of the nerve. Whatever be the diameter, is the tumor encircling the circumference? If yes, then go for PNI positive. Don't confuse. Okay.
Abhishek sir, we have displayed some questions which was sent on the screen. I'll request you to please moderate the same, sir.
The one question is, which risk factor can result in head and neck cancer in a patient?
Okay, so Dr. Ramneet can answer this. I mean, she was the first speaker.
Dr. Ramneet?
Dr. Ramneet is hearing, is here.
Can you repeat the question, please?
The question is, ma'am, which risk factors can result in head and neck cancer in a patient?
So there are many risk factors, like for the oral cavity, the factors are like the oral cavity tumors are caused by tobacco, smoking, and in the oropharynx, we have HPV related oropharyngeal carcinomas. So these are the main risk factors which are involved in the head and neck cancers. Apart from the other gene mutations which play a role in the pathogenesis of cancers.
You see, one point which I want to mention here, in addition to what she said, that in our country, especially in the eastern zone, people chew tobacco, right? So tobacco chewing is most dangerous effect on the oral mucosa. I mean, there is one terminology called multifocal epithelial dysplasia. It's directly related to tobacco chewing. Let me tell you. So smoking, yes, of course, smoking has a bad effect on an adverse effect on the mucosa. Our oral mucosa is very delicate. But if you chew tobacco, it is potentially dangerous to the oral cavity and rest of the part. Thank you.
Right, so there's another question. I think this would be directed for Dr. Nirmalaya. What is considered the priority in treatment planning for patients with head and neck cancer?
Sorry, I can't see. I mean, sorry, please repeat it once again.
Yeah, sure, sir. The question is, what is considered the priority in treatment planning for patients with head and neck cancer?
You see, it's totally depends. As I have said, from the side to side. If you are dealing with a nasopharyngeal tumor, of course, radiotherapy is the treatment of choice. It's a laryngeal tumor, of course, radiotherapy is the treatment of choice. If you are dealing with a tumor of the anterior two-thirds of the tongue, of course, glossectomy is the treatment of choice. But in some cases, we see recurrent tumor, like it's non-operable state. It's very neglected. In those cases, palliative radiotherapy or palliative chemotherapy you have to offer to the patient, but we must try to first to go through the surgical procedure if it is allowed. I mean, it is there possible, and then rest of the adjuvant therapy comes. And also one thing which I want to mention, that regarding lymph node, if lymph node mets are there, they will possibly give after post therapy either a chemo or a radiotherapy. So these things are very important. Yeah.
Yeah, sir, I think a lot of these questions are directed to you. There's another question from Suma MN. It says that suppose a biopsy is taken from a subsite of oropharynx and shows differentiated keratinizing squamous carcinoma. Should we go ahead with P16 staining?
Yeah, it's a good question. You can go ahead with the P16 staining. You can go ahead. There is no harm of going. But let me tell you, see, morphology is the first thing. Whatever ICs you are having, morphology is the first thing. If you are dealing with a tumor which is widely keratinized, right, and it is associated, I mean, it is located in the oropharynx, then you are possibly dealing with a case of smoking related oropharyngeal carcinoma or HPV negative oropharyngeal or P16 negative oropharyngeal carcinoma. Your P16 staining will give you a double proof. Your P16 staining will give you a double proof that you are dealing with a case of HPV negative squamous cell oropharyngeal squamous cell carcinoma. But of course, yes, also I have seen sometimes the keratinization is there, but also diffuse P16. See, exceptions will be there, but most of the times we will find this. Okay.
I think with this, we'll wind up our discussion for now. If there are any other questions, please send us by mail and we'll have the panelists respond to it by mail.
So thank you, everyone. Thank you.
Sure, sir.
Thank you, everyone.
Thank you so much. On behalf of OnQuest, I would like to thank Dr. Abhishek, Dr. Ramneet, and Dr. Nirmalaya for such wonderful presentations and insights. Thank you so much, ma'am. Thank you, sir.
Thank you. Thank you.
Thank you. Thank you, everyone.
Okay. Thank you.